Hello everyone, my name is Sherline Pierre-Louis and this is my presentation that was prepared as part of HAP 725 Statistical Process Control, taught by Dr. Farrokh Alemi. The presentation will discuss the comparisons of a hospital's performance, specifically Johns Hopkins, on multiple indicators when compared to its competitors. The source of the data is from data.medicare.gov. The Hospital Compare archive datasets were used to create the performance comparisons. The measures that were selected include 30-day readmission rates for discharged patients, which include COPD, stroke, and one measure was for readmissions hospital-wide. The readmission measures were selected because avoidable readmissions can be strong indicators for disjointed healthcare systems, and they can also be costly. 30-day mortality rates were also selected for measures for patients discharged with heart failure and pneumonia. Mortality rates are important measures of quality of care for hospitals. It can indicate how effective the care is in emergency medicine. The limitations include missing values, as some facilities did not report or collect some data. There were numerous measures to compare to, but only 5 were selected. And then also some values reported discrepancies within the submitted data, and we actually don't know the true values. After selecting Johns Hopkins as the main organization, to compare it, I chose other research hospitals within the United States. Johns Hopkins is one of the more well-known research hospitals, and it should be compared to others. The list of competitors include Ronald Reagan, UCLA Medical Center, Massachusetts General Hospital, Mayo Clinic Hospital in Rochester, New York Presbyterian Hospital, Duke University Hospital, and the Cleveland Clinic Hospital. This graph shows the mortality rate for patients who were discharged from Johns Hopkins Hospital with a heart failure diagnosis when compared to its competitors. Initially in 2011, Johns Hopkins was within the normal control limits, but the mortality rate slowly reduced, which means the hospital's mortality rates were improving. However, in 2016, the rate increased, but it was still within the normal control limits of its competitors. This graph shows the pneumonia mortality rate. Starting in 2011 until 2015, Johns Hopkins was within the normal control limits of its competitors. However, the rate slowly increased, meaning Johns Hopkins' mortality rate was worsening. Starting in 2016, the mortality rate was above the upper control limit and stayed above the upper control limit in 2017, even though it did slightly decrease. So this graph shows that the rate of readmissions after a patient was discharged from the hospital. The graph shows that initially Johns Hopkins' rate of readmissions was actually higher than most of its competitors, and throughout the years it slowly decreased, and eventually in 2017 the rate of readmissions was within the normal control limits of its competitors. For Johns Hopkins, the readmission rate for stroke patients started off above the upper control limit, but over time it did decrease and stayed within the control limits. The readmission rates for COPD patients in 2013 was within control limits for Johns Hopkins, but it did steadily increase until 2016. In 2017, the rate drastically decreased, which means Johns Hopkins is improving in its readmission rates for COPD patients. In summary, compared to other hospitals, Johns Hopkins was within the normal control limits for hospital-wide readmission rates, stroke readmission rate, COPD readmission rate, and heart failure mortality rates.